مساء الخير دكتور أسامة.
مساء النور، يا اهلا وسهلا دكتوره، شلونك؟
الحمد لله زين، انتم شلونكم دكتور؟
الحمد لله، فضل من الله. ممكن اسوي شير سكرين اذا تسمحي لي؟
نعم دكتور هلال، بليز كو هوست دكتور أسامة.
مساء الخير دكتور أسامة، فرصة سعيدة نلتقي بحضرتك.
نتشرف دكتور هلال، يا اهلا وسهلا.
هسه دقيقة واحدة بس اسوي كو هوست ان شاء الله.
اشكرك.
الآن حضرتك كو هوست عيني.
مشكور اخوي، مشكور دكتور.
الله يسلمك عيني.
يا اهلا وسهلا. شير سكرين. حضراتكم تشوفون البرزنتيشن؟ it's gonna be in okay. بس اذا سمحتم تقولوا لي اذا تشوفون البرزنتيشن and the presenter mode.
واضح استاذ أسامة؟ واضح جدا عيني. هسه بس دكتورة أمنية راح تقدم حضرتك للأودينس، ووراها ان شاء الله يو تيك اوفر، ومن ممنونين مقدما، شكرا لجهودك.
اشكركم جميعا، نتشرف، فضل كبير وشرف كبير نكون معكم.
استغفر الله، انتم متفضلين عيني. دكتورة أمنية تفضلي عيني. الو.
نعم دكتور.
أمنية go ahead.
ستارت عيني.
اوكي. دكتور أسامة please can you just دكتور أسامة.
نعم.
دكتور واضحة السكرين لكم هسه؟
بعدها ما طلعت عندنا.
دكتور واضحة السكرين؟
اعتقد الانترنت يمك شويه بطيء ليقطع صوتك. اوكي.
Now it's clear. Go ahead, Dr. Amin.
Okay. Good evening, everyone. Welcome to day 2 of module 1 of the training course in teaching skills, brought to you by the Medical Education Subgroup in RCP London Iraq Network. This is Umnia, a newly graduated doctor from Baghdad University College of Medicine. I'm interested in medical education and I'm a member in the RCP network. I hope that you've enjoyed yesterday because we sure did. I hope that you get the motivation lessons that we all have gotten from our doctors, Dr. Hilal and Dr. Hassan. This course was like a dream coming true for me because it was like an idea back in 2021. The idea went to be a proposal and the proposal went to be a project, and here I am presenting the course to you. So we continue module 1 with day 2 teaching settings. And by the end of this day, we hope that we've at least explained the teaching settings that we have in Iraq and how to deal with them accordingly, outlined the novel teaching situations and the challenges that we might face in their implementation, and to understand the emerging concept of simulation in medical education. Distinguished speakers we have for today, everyone. And when we want to speak about novelty and technology, we sure should mention Dr. Aussama Nassar. Dr. Aussama is an associate clinical professor of surgery. He holds a board certification in general surgery and critical care in Canada and the United States. He's the program director of the Surgical Critical Care Fellowship at Stanford University. He holds a master's degree in health sciences education from McMaster University, one of the prestigious institutions in medical education. He's a certified healthcare simulation expert and health technology innovator. And among his recent accomplishments is establishing and directing the Department of Surgery Inaugural Residual Coaching Program at Stanford University. Dr. Aussama will tell us about what is the meaning of simulation and how it is like to teach in a simulated environment. Next, we have Dr. Hasanin Al-Taiar. Dr. Hasanen is a consultant forensic psychiatrist and IMG tutor. He is the vice chair of the RCP Psych Southeastern Division. He works at Oxford Health NHS Foundation Trust in Littlemore Mental Health Center and provides in-reach psychiatric care to prisoners nearby. He's a psychiatry lead tutor at OxyPIC project which provides distant learning opportunities to Iraqi psychiatrists. He's also the secretary of the British Arab Psychiatric Association and the chair. He has been nominated to the Royal Society of Medicine's Wall of Honor. His name is now engraved in one of the 40-ceiling glass panels that adorn the central atrium at Wimpole Street in London. Dr. Hasanen will tell us about the different teaching settings that the junior teacher will be exposed to. Reminding you about our schedule, we will start off with Dr. Aussama talking about teaching in a simulated environment.
All right, should I start right now or should I wait for someone?
Apologies. Okay, sorry, just in a couple of minutes. Okay.
Okay. Since I'm the co-host, there's lots of people that want to get into the Zoom
Okay,
link.
so sorry for the Okay, so بس العفو دكتور هسه واضحة يمكن الشاشة ولا لا؟
واضحة.
Yes, go ahead.
Go ahead أمنية واضحة.
Okay, sorry. So then we will go back with Dr. Hasanen at around 10 o'clock, and then we will close the session at around 11 o'clock with your opinions and remarks. Just a kind reminder about the rules. If you have any question, you can type it down in the chat box, or you can raise your hand, unmute yourself, and speak directly to the doctors. Do not concern yourself with the presentations and the materials because everything will be sent to you at the end of the session. Make sure that you stay muted during the session in order to avoid unnecessary noise. And make sure that you register your name and email correctly in the registration form that the team will post in the chat box. And you and your opinions vary the most to us, so do not forget to fill the feedback form that the team will post in the chat box near the end of the session. So make sure that you stick around till the end in order to not any feedback the registration form because it is important to issue your certificates. And finally, follow us on our social media. The links will be posted in the chat box by the team, so make sure to not miss our news and our updates. Thank you so much. I think that's it for me, and back to you, Dr. Aussama.
Thank you so much, Dr. Omnia, for doing this, and Dr. Hilal. This is a great endeavor, and I really feel privileged and honored to be involved in this. Should I share my screen right now, or do you have anything else, Dr. Omnia?
No, please go ahead.
Okay, and you guys are able to see the presenter mode, correct?
Yes, very clear.
Yes.
All right. I just want to know, is there anyone in the audience that does not understand or speak Arabic? Because, as an educator, it's important sometimes to kind of decompress some taxonomies in a native language for better understanding. All right.
Dr. Aussama, some of the attendee doesn't know Arabic very well. So if you mix Arabic and English,
okay.
It's fine. It's fine for us.
Okay, I'll try to I'll just speak mainly to respect these doctors that are joining that are not fluent in Arabic. I'll speak in English, and I'll try to speak very slow. And please, at any point during this presentation, if you have any questions, feel free to kind of pitch in and ask the question. I think Dr. Omnia is moderating the chat, correct, Omnia? Dr. Omnia?
Mm-hmm. Yes.
Okay.
Yes, exactly.
All right. So again, it's a privilege to be here. We're going to talk about teaching in simulated environments. So I'm Aussama Nassar Al-Hiti. I'm one of the trauma and critical care surgeons at Stanford University. As you guys probably know, Stanford is ranked number 4 in the world in terms of medical schools. I'm just saying this not to brag or anything, but just to kind of let you know that I'm alhamdulillah, I'm privileged to be working in this elite institutions, in the United States and in the world. So I learned a lot since I got here 5 years ago. And a lot of it involves my focus, in addition to clinical focus, is medical education. And medical education, as you guys know, has become subspecialty. Just like when you talk about medicine, surgery, medical education has become so subspecialized that you need to have a niche, or you need to have a focus in it. My focus is, as I'll talk later, is simulation-based medical education, particularly as it relates to non-technical skill acquisition. A pleasure to meet you all. I'll try, as I said, to decompress up, because I know most of the doctors here are junior doctors. They're just finished their medical degree. So I'll try my very best to decompress these concepts. And if you have any questions, please don't hesitate to ask. So I don't have conflict of interest. So as we all know, and I'm going to be very basic here, when you design any educational curriculum, you have to have a goal and objective. So the goal is to introduce simulation-based medical education and its relevance to medical education. The objective is to review current theories and novel advances in simulation-based medical, examine the pros and cons of simulation education as learning modality in medication education, discuss the effectiveness of simulation-based medical education as it applies to medical education, and discuss how you debrief or how you teach, in a simulated environment, I'll try to come to that. So we'll try to make this a series, مسلسل. So this is the first exposure to simulation-based medical education. But there will be nice to have some other lectures down the road to kind of help you guys teach in a skills lab. So the best way of thinking about simulation-based medical is a skills lab. So the outline, introduction, selecting mode of simulation, skill acquisition, transfer outcomes, and we'll come back again. So what is simulation-based medical education? شنو معناتها? Any educational activity that utilizes simulative aids to replicate clinical scenarios. So what does that mean? يعني معناتها أي شيء. Okay, I'm going to talk. What does it mean? It means any clinical scenario that you simulate in order to teach trainees or medical students or residents is considered a simulation-based medical education. And it's based on suspension of disbelief. هذه مهمة جدا. Suspension of disbelief, double negatives. So what does it mean? You have to inform the trainees that in order for them to get something out of this simulation-based environment, they have to pretend and think that this is a clear patient encounter. This is actually a patient that they're dealing with. فمعناته لازم يتخيل المتدرب إنه هذه المحاكاة الطبية هي كما يعالج المريض خارج هذه المحاكاة. تكون هي كلها plastics, because there's lots of plastics, lots of things around them. So they have to suspend their disbelief in order to learn. How did it begin? It began in 1930 and aviation, بالطيران and military. And it's currently used in all high-risk professions, medicine, nuclear power plants, business. And you guys probably know that a pilot, in order before to fly an aircraft, they have to do X amount of hours on the sim aviation before they get on a real plane to take off, right? So شلون بدأت السيمulation المحاكاة الطبية? How did it start? There was a pedagogical. تعرفون شنو pedagogical? Pedagogical, it's a very sophisticated word that means educational. If you want to sound smart, put this word in. And people will listen to you. So in 1999, Institute of Medical Report issued a report called To Err is Human. And what they found that almost 44% of the errors, in which American dies from, are due to technical errors, right? So they thought there has to be we have to do better job at preventing these technical errors on patients. So they proposed that you use a simulated environment to allow the staff to practice before going on, before I'm practicing on real patients, like your mom, my mom, your wife, my wife, and your dad, and stuff like that. So you got to practice first on, simulated environment before you practice on humans, and use proven methods such as, you guys going to hear about CRM. I'm sure that most of you have heard about the term CRM, Crew Resource Management or Crisis Resource Management. هذه كلمة تستخدم في الطيران كثير. It's also used in aviation, and astronauts use it, as how to behave when you're under stress. So the more you practice, the more you are able to tackle emergencies and unexpected situations. So that's what it is. All right. And we got to know that all medical errors are expensive. All right. So بس حتى لخص اللي يتكلمون بالعربي, just what it means. The simulation was brought up because there was a need for it due to increasing number of technical errors in the medication and the medical field. So they had to come up with a way to train the surgeons or doctors before they start practicing on humans or patients. So that's the nutshell. Richard Resnick, he was a dean of our medical school back in Canada, issued this very nice, he published this nice article on technical skills in the wind. And basically it was a pedagogical shift, تغير في التدريب الطبي. It used to be احنا نسميها أسطة، مو مسويها تعليم مال أسطة، see one, do one, teach one. أنت تروح تعلم نجارة. If you want to be a carpenter, you go work with a carpenter that would show you how, to do things, and you learn and you become a معلم or a carpenter أسطة. But that's what. But now, why can't we just do see one, practice one, do one? حتى الحلاق يسويها الآن, right? Even the barbers, the barber school, they would practice on mannequins before they would practice on humans, right? Because to eliminate that damage or harm to humans. So why can't doctors practice before they go on, doing surgery on my mom or your mom or my father or your father, right? Or even you, right? So that's the whole concept of simulation-based medical education. So that's why we did it. That's why we teach simulation-based medical. Now, you're going to ask me, you might ask, why are we doing simulation-based medical? Okay, why? Okay, that makes sense, but why? It's because it's patient safe, as you guys saw. It's training center. So the whole simulation enterprise or structure or configuration is in order to help the trainee, المتعلم. كل هذه من أجل المتعلم. So they're allowed to make errors. You could make lots of errors in the simulated environment, but each error on a human being is very costly, right? Availability, it's always there. So you don't have to wait until you get an MI or you get a appendicitis in order to do appendicitis. No, you could just go to the sim center and do it whenever you want, whenever it's available, obviously. And it involves a word called deliberate practice. Deliberate practice. Deliberate practice بالعربي التعلم المتعمد. Deliberate. يعني شنو معناته? What does it mean? It means that you practice with an intention to learn. I don't know how many of us here in this group are surgeons or do procedures, or even just regular, other technicians, other medical specialties. But you learn more when you're always having the constant feedback. And we're going to come to that at the end because it's very important. And it has this option of feedback. Sometimes you do surgeries and you practice with a consultant, but if they don't give you feedback, you come out of the surgery like, I don't know how I did. But the simulated environment has to have a very robust feedback and debriefing after each session. I'm going to introduce lots of theories of education. I do that on purpose to allow you to look it up and learn for those of you that are not medical educators. Okay, so you got to learn about, you have to know the Miller's pyramid of competence, and I'm sure lots of people know about this. Adam Miller shows you that in order to, the highest assessment of clinical skills is shows how and does. An example of that, MCQ هو multiple choice question. He knows. بالعراق احنا كنا طلاب كل MCQ وبعدين عندنا عملي صح؟ استاجيري كنا بالمستنصرية. So MCQs is how you assess what you know. أنت استاجير, how you examine, how you do surgery, does and shows how. Simulation actually assesses the highest two in the Miller's pyramid, which is shows how and does. Now you talk, okay, Osama, we're all sold on this simulation modality. We're going to adopt it. We have a skills lab, but which one should I choose? Which modality fits my need? That's a great question. So as we all know that the cadavers, الجثث أنا من بالمستنصرية من التسعينات, we had cadavers. The cadavers, have been used since the the dawn of century. I think Ibn Nafis, Ibn Sina, but used to use them. So they're still used. In fact, I'm teaching a course, a surgical course next week on a cadaver at Stanford. So we still use them. They're very effective. They're very real, but sometimes they're hard to get at. There's mannequins. It's available. There's lots of types of mannequins. And we have the standardized patients. هو المريض المتدرب هو. So for what it is, it's you get a medical student or get someone in North America. We hire people. There are medical students, nursing students. There are people just in the community that they were patients and they like to help doctors, and we give them money actually per hour, and we train them to be involved as simulated patients. So this is not a real patient. This is simulated. They put moulage on them and make them feel that they're real. And then you have the virtual reality, which is really taking off right now. المحاكاة عن طريق الكمبيوتر, العالم الوهمي والافتراضي, المحاكاة الافتراضية, virtual reality. It's a new game changer in simulation-based medical education, and I think in few years this is going to be the gold standard. You're going to be putting on, some, goggles and having a little setup at home, and you'll be doing most procedures and clinical encounters at home. I published this nice article with Dr. Aussama. I'm sure you guys know him. Mashallah, he's very active. He's one of my very close friends back in Iraq. We published a few articles, him and I together, and it's really nice. You guys could go and reference it. We published it last year, I believe. Part task trainers is another simulation modality. Here, how to learn intubation. So if you want to learn intubation, you do the part task. If you want to learn a lumbar spine, is another. And you have the hybrid mode, which is very interesting. So to simulate a lady that wants to give birth, okay, you get a mannequin on the below part, and then get the patient herself to create that, and you get the husband. See, that's also a standardized patient standing beside the simulated wife to create that fidelity. الواقعية حنسميها. You got to know this word called fidelity. So any science has its own terminology. Medical education comes with lots of terminologies today. So I'm exposing you, inshallah, to all of these terminologies. So you could see here that there's a woman that's giving birth, and there's a mannequin down below, and this is like kind of training the nurses with the obstetricians or residents on how to deliver a baby. Okay, so it's very nice. I use it sometimes in trauma settings. And this is the theater-based. So theater-based, I call it theater-based. Lots of people call this. هذه هو المحاكاة العامة حتى نخلق بعض من السترess. It's called stress inoculation. الحقن بالstress. And what it is, we get someone like this person that is miraged, كل حاطين له مكياج, and pretend that this is a real scenario to allow that simulated psychological fidelity, الواقعية النفسية. Okay, Osama, يعني أنت شرحت لنا all this, but which one should we choose? And we know what's on the menu. We're all kind of biased to what we like. So, الفيداليتي الواقعية, ما هي الواقعية? It's not easy. If you look it up, there's lots of definitions for it. I like Hamstra's definition. We're going to come to that. The degree a simulator looks, feels, and acts like a human patient. الطريقة اللي هو المحاكاة تبدو ولمسها وواقعيتها. يعني أقرب شيء للإنسان هو الكدافر. The closest thing to human is cadaver. So that's why we use this. So dimensions of fidelity. There's types of fidelity. It's structural fidelity. So شكلها, how does it look like? And there's functional fidelity and what it does. And there's psychological fidelity, the degree to which trainees perceive simulation to be a surrogate for the real task. اللي هي الواقعية النفسية. Okay. أسألوني سؤال. Okay, Osama, then هل fidelity leads to higher skill acquisition? Okay, I'm going to ask you this question. دكتورة أمنية, ممكن تخلقي لي poll A and B إذا تقدرين.
تمام ثواني دكتور هلال، لأن أنا مدى يطلع يمي البول.
Okay. أنا عندي يمكن ما أعرف منو عنده. Okay, it's not a big deal.
Okay, so we can use the chat box.
Okay, chat box, whatever, that's fine. So, so ask a question to the audience, please. I know we have 101 participants. This is really good. Which modality is associated with higher skill acquisition and learning ureteroscopic ureteric extraction? Is this the lower field? What you see on the lower side, lower left side, the low fidelity, is a little styrofoam box, glass filine, and has two straws, قصبات اثنين, and has a little plastic tubing, okay? Versus this very sophisticated on the right that has the whole thing, right? The whole thing, even, the penis looks real, the ureters are all assigned well. So which one you think of these will lead to better learning? Go ahead in the chat box. I'll give you guys 10 seconds.
Okay, so most of them
A or B?
have already answered. Most of them are going with B.
كم واحد? How many? تقريبا.
تقريبا 40 دكتور.
Okay. 40 ممتاز. So, okay, there's a poll. I see a poll. Someone is polling. Okay.
هاي أنا هسه سويتها أسامة تدلل.
عاشت ايدك دكتور هلال، بارك الله بك. I'm admitting everyone coming in, okay? I'm helping you, Omni. I'm doing your work too.
Thank you so much.
All right. خلصنا مو دكتور هلال؟
خلصنا. هاي sharing the results now.
Okay. أريد واحد. I want someone from group B. Oh, well, yeah. I want someone from group B to go off mute and tell me why. أريد واحد من group B. أدري تبيكم منعسين ساعتكم الساعة 10 بالليل. الله يعينكم. احنا عندنا 10 الصبح، انتم عندكم يمكن لسه متأخر. لا 10 بالليل إلا شوية.
Okay, so anyone can just raise his hand and talk to the doctor. Dr. Rawa is saying B is more realistic.
دكتورة رواء ليش؟ Why؟ تعتقدين أن شكلها يعني صحيح؟ هو يعني أفضل؟ Okay. All right. So the answer is A. على الأسف. There's no difference actually. Okay. ليش؟ لأن هاي دراسة, this is a study that was done. هذه شفتكم إياها what you see here, was a master's thesis dissertation done by a person that I used to work with in Canada at McMaster. His name is Edward Matsumoto. He's a urologist. It showed no significant difference between the high and low fidelity groups, right? And guess what's the price difference between them? $20 versus $3,700. تخيلون ولا ما تخيلون؟ هذا $20 وهذا 3,700. بس اثنيناتهم, the learners rated that they had the same learning and what they got out of it, the same exact learning. So sometimes the looks don't matter. It's how the feel, it's the experience that matters. We're going to come to that, okay? نيجي على concept أخرى. Then there's another paper that showed the same thing. There's, less fidelity. So that's why they got rid of the word fidelity, and they now, come up with what we call functional task alignment by Hamstra in 2014. Some people don't believe in this. I think it's a full mouth term, but what the point he's trying to get away is, if the mannequin or the simulator يعني الأداة, simulation هي المحاكاة, is the process of learning. If the simulator looks like very expensive, it doesn't always mean that it's better than the least expensive. And we're going to come to that, okay? So they went away from physical resemblance to functional correspondence. That's what functional task alignment means. مثال على غرار ذلك. دكتور الله يرضى عليك, ممكن نسوي دكتور هلال تسوي لنا poll A and B, suturing skill. أي منها, which one of these would best be utilized to teach students suturing skills? This chicken leg cost Allah يدري قد, or the Simman 3G. This Simman 3G costs like $60,000. يعني BMW X7. السوقة هي هذه السمان 3G. It cries, as you could see. شوف حتى تبكي هاي, شوفوها تدمع. يعني هذا عندنا اياها. You might have it in Iraq, I don't know, but we have, even in the United States, there are not that many because they're very expensive. It's by a company. So go ahead, please. If you could open the poll for 10 seconds, that'll be appreciated.
Yes, we have a 25, 26 and counting.
Yeah.
Most of them are saying A.
عافية عليكم, عافية. We're learning. فمو معناته كل شيء sophisticated and complicated and costly. Yeah, I think this is the old poll. All right, that's fine. So the chicken leg is the best teaching. ممتاز. هسه طلعت عشتيتكم ما شاء الله. Okay, so هاي مهمة جدا. This is an important concept. Then always you choose a modality that fits your need, okay, and fits the goal from the teaching exercise. So that's why you have to first, in any curricular design, المنهج, تصنع منهج, the first thing you come up with is to put the goal of that teaching session. شنو أنت راح توصل للطلاب من هذه? So if the goal is to learn A, B, and C, then you choose your teaching modality or simulation modality to fit that need. Okay, so that's what it is. Okay, so that's why A. ممتاز. Okay, what about this one? Which one is the best one, if modality, to teach laparoscopic suturing? The lap sim or cardboard lap box? وليد واحد ممكن أنا أكره بس أنا أحكي. I hate that I'm the only one talking. It would be great if we do it like a little bit, interactive. Which one is you would choose, A or B? And I want someone to explain to me why, please.
Okay, please go ahead, Dr. Nassar.
يا أهلا دكتور نصير تفضل.
السلام عليكم دكتور أسامة، عيني عاشت
نبي
ايدك
الغالي. يا وسهلا.
على البرزنتيشن. أنا حقيقة أيد دائما اللو كوست، والمشكلة إحنا مو باللو كوست والهاي كوست، المشكلة بالقائد اللي يدير الأمور. إحنا الليدر والمنتور والتيتشر اللي يدير الأمور يعيشهم لازم بأجواء الحقيقة.
عافية عافية عليك.
هاي الأجواء هي اللي حقيقة تحقق الهدف من الليرنينج. فاحنا بالسيميوليترز، يعني انا اشوفها بالعراق والبلدنا، يعني انا افضل دائما اللو كوست، خاصة بالاعداد الكبيرة اللي عندنا من الطلبة. بعد ما اعرف، هذا الرأي لي. شكرا جزيلا.
اهلا وسهلا. منو عنده
Dr. Salman, please, if you comment in English for some of the listeners. Dr. Osama, عفوا.
تفضل عفوا. Yeah. So Dr. Nassar mentioned that the cardboard lab box is probably better teaching modality to teach this, given that it's low cost and will fit the needs in Iraq, given the sheer number of learners that we have. So I agree with Dr. Nassar 100%, and that's what the purpose of this is, to get to you, because we don't have much resources in Iraq. I think so. I mean, so that's why we got to invest in us learning what to teach the students, because what we call it cost effective, the lowest cost and highest effectiveness. That's what we need to do. Thank you so much. Here, this is going to be a little bit of a dry topic, so I apologize. هذا سيكون موضوع شوي جاف, and I apologize, but I'll make it easy. So this is important. Why I have to put it there? So the more you learn about, get exposed to teaching theories, the more your horizon will expand, especially for the junior learners in the class. So technical, skill-based text, non-technical. You're going to hear these two words a lot. Technical skills, non-technical skills. You're going to hear this a lot. Technical is skill-based task. What does it mean? Suturing, cutting, doing surgery, technical, right? Non-technical is how I communicate, my professionalism, my interpersonal skills. شلون أقدر أتعامل مع المجموعة بالشغل شلون. But this is important. Technical skills is much easier to teach by the non-technical. Trust me, it's very hard to teach someone how to communicate and how to be professional. And while you could teach even a monkey how to do some technical skills, correct? So there's an informational processing theory. You will not be able to understand how you have technical unless you understand. This is very important. Information processing. With the computer, you have input. A learner like you guys have input. You perceive it through your eyes, your ears, and your touch, haptic feedback. And then when the perception comes, you manage it in the brain, the processor. Like a keyboard, processor is the brain, and action, output. You do surgeries, right? So that's what it means. Now, there's Fitz and Posner are two lead educators, and they came up with a motor skill acquisition theory, okay? And what does it mean is that there is, sorry, I'm just gonna have to, there's stages to that. So there's associative, so there's cognitive phase, there's associative phase, and there's autonomous phase. So what are the differences? I'll give you an example. When you first learn how to drive a car, أول ما تعلم سوق سيارة. And that's not the automatic car. Go back to where I was when I learned how to drive a car in Baghdad. Is the drive shift, right? السيارة العادية ملقية. You read about it, right? Your dad shows you, or you might steal your dad's car in the afternoon. I mean, he's taking a nap, and you go or drive like I used to, and you are overwhelmed by the mirror, by the steering wheel, by the gear, by the clutch, by the gas, and by the brakes. تقول شلون هاي الواحد يسوق هذا وهاي وهاي ما تقدر واحد يسوق. That's called the cognitive phase. So that's when the learner starts. على أول ما تجي أنت كلية الطب أنت you're all overwhelmed. You teach them a skill. They're hard for them to do a lap chole and a laparoscopic cholecystectomy. But you could see this circle with black on it. The black part in the circle portion, the black portion of the circle is how much cognitively overload. There's another theory called cognitive overload theory. شنو cognition? Cognition هو الاستيعاب. So when you learn how to drive a car, your brain is so overloaded by all the sensory stimulation. من الإيد, من الsteering, من, making sure everything. So all this cognitively overloads, and you have very small amount of free memory. High free memory. High free memory is if someone talks to you sitting beside you, right? You could answer. But sometimes you tell them, please don't say a word, shut up. I cannot focus on you because I'm going to crash the car. And then slowly you start to learn and become associated face. You learn how to handle the steering wheel. You learn how to, and you free more of the white part. So the white part is the free memory, the RAM and the computer. And the black part is how much cognitively over until you become a consultant, autonomous. When you guys drive a car, you could chew a gum, talk, listen to music, right? And go on your cell phone, right? And drive a car, which is not something you should be doing. So that's called autonomous when it's all these. So that's why when I've been practicing surgery for a long time. When I do surgeries now, I could talk, I could, listen to music, and talk to patients. But when I'm in a critical part of the surgery, I go back to the cognitive phase. This is important, okay? I published this, by the way, the same article. This is very interesting. Important aspects of technical skill acquisition. It's highly deliberate practice. Al-ta'allum al-muta'ammad. I wish I could speak Kurdish for our Kurdish friends, but I can't. Deliberate practice. So what is deliberate practice? It's highly structured, okay? It means that al-ta'allum al-muta'ammad, which provide by it has to be highly structured. You go to a sim lab and you tell them, you're going to learn this and that. You're going to learn how to suture. I want you to learn how to put the suture needle, load it on the needle holder, perpendicular to the skin, and rotate your arm and do a simple knot. Okay, structure. Goal to improve performance. The reason why they're doing it is not because to earn money, just to make money or to get the job done. No. It's to improve performance, and it has to have feedback. So the most important aspect of all this is the feedback. If you don't have a feedback mechanism on any training simulated practice, then you are in a bad situation. So feedback is important, right? And sorry, let me just get back. Feedback. There are two types of feedback. There's augmented feedback, which means outside. So you have a consultant telling you what to do, right? Or you have a computer in VR sets, the computer tells you what to do. And there's intrinsic feedback. What does intrinsic? How the feedback that comes from the tissues, how the tissues feel, how the tissues handle. So which one has the most highest intrinsic feedback? Is it the chicken leg or the plastic? Of course, the chicken leg, right? So that's called intrinsic, okay? For example, haptic, that's called haptic feedback, part of the intrinsic. All right. And then you have, now we finished that non-technical, we'll come talk about briefly about non-technical skill acquisition. Non-technical skill acquisition is a little bit of a topic on its own. And this is my specialty more than the technical, because this is what we need. And I'm specialized in both, but my research right now and my funding is mostly on non-technical skill acquisition, because that's a new branch in medical education in the United States and the world, because they finished the technical, they figured it out. Now we need to figure out how we teach trainees non-technical skills like communication, leadership, crisis resource. It's called, these are all called career resource management. Leadership, teamwork, communication, situational awareness, decision-making. They're not the procedural skills. And there's like ants from University of Aberdeen and non-technical skills. And this is what it looks like. It's, again, beyond the scope. I just want you to be exposed to it. Why is non-technical skills hard? to teach because we don't have experience in technical. I don't know, even in the United States, there's not many curricula on communication, leadership, on interprofessional situation. We don't have that. So we don't have expertise as faculty in teaching these skills. And there's lack of pre-simulation training and lack of reinforcement. You teach them something in the simulator. Okay, you have to communicate with the patient well and do this, but they go out and they see you not communicating well with the patients. So guess what? They're not going to change their behavior. They're going to do what you're doing. This is called a hidden curriculum in medical education. And there's lack of transfer to real life settings. So does the simulation, okay, Aussama, you've done an excellent job today. You told us about simulator, but does it work? Really? Does it work? Okay, here's the evidence. I don't know how many of you heard about Kirkpatrick's program evaluation pyramid. Very important. For those of us that do lots of program evaluation, we talk about Kirkpatrick pyramid or hierarchy. So there's reaction, there's learning, there's behavior change and impact. So the lowest evidence is reaction. How did the simulation go? It was great. We loved it. High some reaction. Al-infi'aliyya is low evidence. The learning is, yeah, I learned a lot from it. Okay, but did it lead to change in your behavior? هل أدت إلى تغيير في السلوك اللي عندك? More importantly, did it lead to impact? And what is the highest impact in medical education? Highest impact, saving patients' lives or decreasing patient complication. And كل infrastructure, institution in the hospital or enterprise is for the patient. The patient is the superstar of our enterprise. So if we don't benefit the patient, all of this is meaningless. So all the medical schools is for the patient. So if we don't serve the patient needs, then we've missed our objective. So that's the objective, is to improve patients' life and their quality of life. So what are the simulation-based limitations? Surprising scarcity of data on performance of these tasks in patient follow simulation training. But there's okay, I'm going to just go with, because of time, I want to focus on the other part. I'm going to go over time for 5 minutes. So they've done a study on central venous line insertion, you know, the central line, they put it through IJ, internal jugular vein, and they saw there's 85% reduction in central line infection after you taught them through the simulator. So it does improve outcomes of patient outcomes. Now, I added this based on Dr. Omnia's request, and thank you for suggesting that, is debriefing. So the imperial, there's lots of debriefing acronyms or taxonomies or on how to do it or frameworks. I like that one from Imperial College of London, the SHARP, it's easy. So the first step is to set, so إذا عندك أنت skill lab, you have a skill lab. What are the things you do? So first thing you have to come up, you're going to say, what am I going to teach the learners? What are their objectives? 1, 2, 3. And then the most important, after they go through the sim session, you have to, they all agree, how did it go? شلون صار؟ شنو رأيكم؟ شلون صارت أنا بترجمة بالعربي. How did it go? شلون الأمور؟ شلون صار؟ شنو رأيكم بالsimulation session? They want to get that psychological decompression because sometimes it's stressful. So they want to express how they thought it went, right? And then you address concerns. Oh, I had this issue in this simulation. I wish I could have changed it. So that's you address the concerns, right? And you go then circle back to the learning points, the objectives. Say, hey, you're supposed to learn this, you're supposed to learn that. These are things that we need to work on for next time. Okay, that's the plan ahead. Is that clear? Very nice, simple, and you could use this all the time. And you sharp, don't forget, setting the learn objective. How did it go? Address concerns, review learning points, and plan ahead. Okay. Another way of doing this is the debriefing is before the case. Okay. After the case, address concerns, and this tells you what to say, right? And then you plan ahead. So these are, very simple. By the way, debriefing is another presentation for another hour if you want to do like a workshop on how to debrief, because Debriefing is the heart and soul of medical education. Okay, don't forget that. Feedback and debriefing is the cornerstone. The most valuable part of any sim session is the debriefing. If there's no debriefing, the learners might not learn anything. Okay, so does it work? Yes, it does work. Simulation-based medical education, it does work. Fidelity replaced by functional task alignment. We talked about that. FTA is defined according to the goals that you set before, a priori, and قبل السession, before the session. As promising teaching tool in medical education improves learners' outcome, patients' outcomes. It is a resource intense. تحتاج, it's not only resource money intense, it needs lots of faculty to be trained in simulation-based education modalities. It's something we're exploring with high quality research to show that it does improve patient outcomes. As I said, the top pyramid is patient outcome. So if it leads to changing patient outcome, that's what we need to do. All right. So thank you so much. And I appreciate everyone's attention, and sorry to go over time, Dr. Hilal and Dr. Omnia. Any questions?
Thank you so much, Doctor. But you still hasn't gone over time. You still have 5 minutes. Actually,
Okay, I thought you said 45. That's good. أسئلة? Any
Yes.
questions?
Please, I have one.
No.
Yes, go ahead, Dr. Hilal.
حقيقة دكتور أسامة أمتعتنا بهذا التقديم. يعني طريقة التقديم، الكونتنت مالته، المسائل، المسجز وصلت يعني بعمق deeply حقيقة. بدي يعني you highlight a point اللي احنا محتاجيها بالعراق، وهي what are the training courses for those working at the skill labs have to do, what level, what specialty they should have, for how long they did do it, because really we are in need for such facilities. I think at our most of our medical schools, I cannot say all, there are no professional, well-trained personnel to do that. And I have some experience with some of the UK universities. I found there is skilled nurses trained on that to do the job. And I think this can be fitting our environment, because there wasn't a lot of doctors to be free to do that job. So what is your opinion about that, Dr. Osama? Thank you.
تشرف دكتور هلال، أشكرك. Thank you so much for this interjection and المداخلة هذه، أشكرك عليها. Very good point you brought up. If you don't mind me asking, Dr. Hilal, who do we have any stakeholders عندنا مسؤولين in the medical schools here on this meeting or not? I just want to know.
نعم على الأقل ويانا 3 أو 4 عمداء من كليات الطب، دكتور نصير، دكتور أمين. I think يعني I'm sorry if I forget someone, but اللي قدامي موجودين. نعم
ممتاز.
نعم دكتور.
نعم نتشرف بكم، بس حتى نعرف يعني it's something I think there is, it's a loaded question, and I'm happy, and again I said this before in prior lecture, I think Dr. Nassar was there, if we could get together for an hour online, and we could go through ways we could augment and enhance the simulation-based education effectiveness in Iraqi medical school skill lab. I think it's doable. We need more than money. We need experience and training the educators in the principles of simulation-based medical education. It's not hard. As you said, Dr. Hilal, very good point. You could train even nursing. Like we have one of the best simulation technologists is the nursing staff, is one of the nurses. She's specialized in simulation-based medical education. She prepares all the lab for me, and I'm, as an educator, just go there, do, supervise, put the educational goals, and do the debriefing. So there is a system, نخلق نظام, system for that. So I just bring this all the time, Dr. Hilal. That's a very good question. In Emirat, they have $1 million simulation centers. صدقني, Emirat. They don't know what to do with them, right? They have the money, They have the infrastructure, but they don't have the skills and how to teach, how to utilize all the SIM technologies to benefit the educator and not forget to benefit the patient. So that's what it is. It needs someone with a vision that creates the system. A system يتكون comprises, number one, a sim lab. As we said, it doesn't have to be high fidelity, it doesn't have to be costly. This is the message I want to get across. You could do this with low resource, low cost, and then train a team of simulation experts and creating a role called simulation lab director or simulation director. And that director is responsible of training the center and getting that center certified by the Ministry of Higher Education. يعني لازم مكان بالمنستري of Higher Education حتى تسوي certification هو SIM center. يعني in the United States, to be a SIM certified, it has to go through rigorous assessment. فهمتوني؟ فلازم there's like a structure for that. And I'm happy to help with that as much as I can. All right. And also Stanford is willing to help because we have a collaboration now, I think, with Jamiat Al-Anbar. We're starting that. So we want to create more collaborations in the near future with other universities.
Excellent, Dr. Oussama. I think we have to arrange another course or another session to go for more details about that, Dr. Oussama, and we will do it in the future, inshallah. Shukran jazilan.
Excuse me, doctor. We have Dr. Muhammad Saeed, who has raised his hand.
تفضل.
شكرا العزيز دكتور أسامة على very nice presentation, very useful بصراحة يعني وهي مفاهيم a new concept I learned from you. About communications, we have alhamdulillah أشكر صار لنا يعني many years we are teaching communication skills يعني. What I use instead of bringing actor or bringing standardized patient or something like that, I invite the student themselves, one of them, to present his illness before, like headache or abdominal pain or whatever problem he passed through in the past, because he will present a real situation, real life, contain both physical, psychological, and social part, patient perspective, his concern, his everything. We can learn it as if you are dealing with a patient. So we are not bringing actor to simulate a patient, but we alhamdulillah we did it very successful when we teach undergraduate, and even we when teach and train postgraduate and even physicians. What is your opinion about that?
You know, I must say, Dr. Muhammad, mashallah, I brought a very, very valid point, mashallah, that's being creative, innovative, resourceful, and how to train the students with low resources. So this is what we want to do, Dr. Muhammad, is clone you and get you in Iraq so you could utilize what resources we have in order to best benefit the learners, because the easiest excuse for not teaching is that, well, you know, the government doesn't give me any resources, right? Why am I teaching? Why am I doing? No, you got to work with what you have. So in order to fulfill the mission of being an educator. Thank you so much, Dr. Muhammad. That's a very creative. Shukran al-mudakhala.
Thank you so much. Next, Nassir. Nassir, please go ahead.
السلام عليكم.
عليكم السلام.
شكرا عزيزي دكتور أسامة. حقيقة بس ردت انه يعني اوضح لك، ترى كليات الطب العراق عندها يعني عندها كثير من يمكن دكتور هلال مطلع علينا احنا في طب واسط من 2012 عندنا سكيل لاب حقيقة ب a lot of models for simulation، واحنا دائما في تطويره ومتخذيه كانما شلون نقول انه فد هوسبيتال سيميليتر هوسبيتال سيميليشن هوسبيتال فور ذا ستودنت. انا ارجع واقول دائما انت عاشت يديك وضعت الحل للجروح، انه يجب ان يكون عندنا ترينرز اللي هو شلون نقول سبيشال انترست بهذه الامور. يعني هذه يعني لاحظتها دائما، هي هنا تصبح المشكله انه نجيب الاساتذه اللي عندهم واهس انه يدرسون بالموديلز، اللي عندهم خبره بالموديلز، وحقيقه هاي سوينا لها هم عديد من الحلول. والحمد لله يعني اعتقد انه الامور يعني تمشي، وان شاء الله نتواصل انا وياك بحيل الله نطور هذا المشروع، لان انا عندي هواي افكار بيه، وان شاء الله نتقدم للامام.
ما شاء الله عليك. أريد أقول يعني هنيك. I want to congratulate Dr. Nassar. I know him very well through Dr. Faiz. I know him through Dr. Faiz Ta'ma. And Dr. Nassar is Wasit, I think, is one of the I don't know the others that I know of, advanced medical education. The fact that Dr. Nassar as a dean is attending this session tells you a lot. صحيح ولا لا؟ لما نشوف واحد عميد يحضر ويتعلم ويسأل، هذا هو, this is what we need. It's like Dr. Nassar is to be able to they want to improve their education. So it starts from the dean, and you're right, Dr. Nassar, you have to have a stakeholder. You have to have a champion, assign a champion. You give them a salary, but provided they're interested, and this is what you want to fulfill, you got to get it done. And we'll be happy, myself, Dr. Faiz, I know for sure, Faiz is a very good friend of mine, to help out, as any way, shape or form. نقدر نساعد بلدنا الحبيب بكل ما نستطيع.
الله يحفظكم والبركة بيكم. وحقيقة ما أبخس أنا حق العمداء اللي قبلي، من دكتور عطا، من دكتور حسام، هو قائد حسام مجيد، ما أدري ويانا أو لا، هو حقيقة قائد النيو إديوكيشن، وهو قائد هاي التغييرات. أنا ترى هم استلمت وراهم. يعني
أنا لا آسف ما أعرف الأخوان البقية، بس أشوفك أنت دائما الشارك وتحكي، والأخوان نشرف نيجي هنا.
الله يحفظكم.
Excuse me.
دقيقة أديان ويانا أيضا أستاذ أمين عميد طب حمورابي، دكتور أسامة همنا موجود ويانا أيضا. عميد
نشرف. شرف.
العفو، تفضلي أديان.
Dr. Muhammad Omar also, please go ahead.
Thank you very much. Thank you very much, dear Dr. Aussama. It's nice, and I'm glad to listen to your nice presentation. I'm Dr. Muhammad Omar, Professor of Medicine from College of Medicine, University of Suleimani. And I am the Director of the Arab Board for Internal Medicine in Suleimani, as well as the Program Director for Gastroenterology in the Kurdistan Board for him. It was interesting, really. We have this skill lab in the College of Medicine for more than 10 years, and we get benefit from that for the undergraduate and postgraduate. We have the SIMMAM and the others for the resuscitations, and for even learning our students regarding suturing, intubation, management of the arrhythmia, etc. And till now, I arranged more than 3 courses for the board students for 2 weeks about the ALS and ATLS and other training courses. And we invite some of our colleagues from the Canada, Dr. Schler and Dr. Irfan, who are international advisor for that training courses. But what I want to add is that sometimes we need further training facility. For example, in gastroenterology, when we want to teach our students regarding some new procedure, for example, simply removing a polyp or doing a new endoscopic procedure, there are special simulator, some of the companies arranging that. One of the meeting in Hawler many years ago, thankfully, with our colleagues from the UK, from the British GI Society, they bring with them some prepared model from pig, or we can do it here in our area. We have little pig, we can do it from sheep or others. So how is easy or how much is difficult to prepare this model for this procedure, especially, even for the specialists in the learning curve, some procedure need time, especially the endoscopic procedures. So preparing this model, how you can help us in that aspect. Thank you again.
Thank you so much. It's been a privilege, Dr. Muhammad, to meet you, mashallah. You have a very established clinician and a leader in Kurdistan and Iraq. So I'm an endoscopist too. I do lots of advanced endoscopy myself. So there are ways, and there are, high high fidelity or very costly models. In the United States, we have now the, I don't know if you've seen it or not, Dr. Muhammad, it's like the endoscopy, the scope with a mannequin. So it's a hybrid virtual reality and a scope. So that's a mannequin that we use for the early learners on how to handle the scope, how to navigate the scope. And it has polypectomy and all that, which they learn the steps. And now there's for advanced learners, which we for polypectomy, fulguration, all that. There is, believe it or not, the easiest way of doing it. We get stomach sheeps, sheep stomach or pig stomach, pig, and then we do the same thing, and we get the claw, all these advanced and banding. We create a polyp by putting a little band around it, and then you do polyp, and then so this is, I think, to me, because I learned this through that way. This is the most effective in getting the endoscopist over that learning curve to be comfortable and confident on doing it themselves. I'll be happy to help with that and setting it up. If you're not, I'm a busy person here, but I would love to help any one of you in achieving any of their educational goals and be part of that. So thank you. So you have my email. I'll put my email there if anyone wants to reach out to me.
Yes, please. Thank you very much. Yeah.
No problem.
Thank you so much. And next we have Dr. Amin, the Dean of Hamravi University. Please, Dr. Amin, go ahead.
Yes, thank you so much. حقيقة يعني نايس برزنتيشن دكتور أسامة، شكرا جزيلا على هاي المعلومات. بس حبيت أن أعطي كومنت مهم جدا، إنه القضية المالية بالحقيقة الآن في كليات الطب والتعليم الطبي العراقي صار عندنا برانج من الموضوع البجت اللي هو نحصل عليه من التعليم الموازي. فبالحقيقة الآن السكول لابز الآن ترتبت بشيء أفضل مما كانت قبل حوالي سنتين، لأن قبل سنتين صدر الأمر لأنه قضية الموازنة المالية في التعليم العالي حقيقة ضعيفة وقليلة، فتعوضت بهذا المجال. إضافة إلى ذلك أنه إحنا حقيقة عندنا في جامعة بابل دكتور أسامة،
نعم.
في كلية التمريض أعلنت السمارت كولج في عام 2016. أنا عميد من 2015، في 16 أعلنتها، لأنه أنا وجدت التعليم الطبي الصحيح هو والقريب من اللاب communication with the student and curriculum حقيقة بيرفكتلي. إنه من رحنا إلى اليو كي وسوينا تويننج جامعة بابل النيرسينج كولج ويا نورثهامبتون، وشفت هناك كل الأشياء الحقيقة المسجز سويناها إلى واقع حال واشتغلنا فيها. الآن أنا صار 3 أشهر تكلفت أن أكون عميد كلية الطب، فاجيت لقيت ما شاء الله الأخوة بادئين بداية، لكن أنا شوية كثرتها ب3 أشهر، لأن تعرف الميزانية المالية إذا بقت الفلوس ترجع. فإحنا الحمد لله أنا خلال 3 أشهر صفرتها، بحيث اشتغلت كلها لاب سكيل كوميونيكيشن. شكرا جزيلا دكتور.
اولا ارحب بك دكتور امين، الشرف بحضرتك. سعيد جدا بان اسمع اتعرف بالاخوه والزملاء في العراق الحبيب، وما شاء الله عليكم. يعني انا افرح لما نشوف عمداء بال9 بالليل يوم الجمعه بالليل يحضرون، يعني او مسؤولين. يعني هذا مثل دكتور محمد attending at this late hour. This is a big vouching that there is acceptance in the Iraqi medical system to improve the educational, status quo in Iraq. So I really congratulate you all. And shukran jazilan, to everyone, and appreciate you're doing that. And I'm happy to help. I'm happy to help everyone here with what I have.
Thank you so much. I guess the time is over. We would go into 10 minutes break. Thank you so much, Dr. Aussama, for the amazing session. Everyone, we are going into 10 minutes break. See you after 10 minutes. Thank you so much.
Thank you a lot, Dr. Hassanen. Thank you a lot.
Everyone, welcome back after the break. I hope you get a warm cup of tea in this cold weather. So next we will be having Dr. Hasanain Al-Taiar. Welcome, Dr. Hasanen. We've missed you so much. Dr. Hasanen is a consultant forensic psychiatrist based at Oxford. Dr. Hasanen will tell us about the variety of teaching settings out there and how to manage them accordingly. The floor is yours, Dr. Hasanen.
Thank you very much, Omnia. Happy New Year, everyone. Thank you for the invitation, Dr. Omnia, Dr. Hilal, and everyone else on the Zoom call today. I'll try and speak in English as I think per Omnia's request and Dr. Hilal's. Good to see you all and Happy New Year. And I was just thinking about probably the first lecture or tutorial I gave. It was more than 18 months ago, or it's probably around mid-2021. So congratulations to everyone who's been working on this fantastic group and network between the Royal College of Physicians and and Iraq. I sadly couldn't attend to the second anniversary of the network on the 9th of December due to clinical commitment here around Christmas time and cover arrangements. Dr. Hilal kindly invited me and sadly I let him down, but next time inshallah and I will be there. I'll be the first one to attend.
مكانك خالي حسنين.
الله يسلمك دكتور. قريبا ان شاء الله يعني تطلبوني زياره او Thank you. I'm trying to share my set the host disabled participant screen sharing. Could you?
Yes, Dr. Hilal, please co-host Dr. Hasanen.
Thank you. Thank you. So it's not going to be a long tutorial. I know it's like what 10:30 or 10:20 in Iraq. Thank you.
حسنين co-host الآن تقدر تسوي sharing عندي.
Thank you. Right. I'm hoping this will work. Can you see the slides? I tried to make the
Yes, it's clear.
Thanks. Trying to do the slideshow. Oh, yes. So, yeah, congratulations to the RC, the Royal College of Physicians and the Iraq Network. Dr. Hilal and colleagues have been working really hard and endlessly over the last few years to establish and flourish this network of great medical educators and trainees and in collaboration with the Royal College of Physicians. So great efforts that need to be commended. As Omnia said in the slide, oh yes. So yeah, as Omnia said in the introduction, it will be around a basic idea of teaching sessions, what kind of teaching sessions we use in clinical medicine and clinical and non-clinical and theoretical sessions. I am a psychiatrist. I qualified in Iraq many years ago and went to the UK, and I have a higher degree in medical education from Oxford University, and I also work as a forensic psychiatrist in the National Health Service. And I'm the chair or vice chair of the Southeast Division of the Royal College of Psychiatrists, where we promote the voice of psychiatry in the Southeast, organize lots of educational events, and I chair the England Mental Health Act approvals panel, where we approve doctors who are kind of specialists and consultants under the Mental Health Act to practice independently in the United Kingdom. I was so lucky and humbled by by being volunteer. My name is on the Royal Society of Medicine Wall of Honor. This is I think something like golden plated. Alhamdulillah, I'm probably the second Iraqi whose name is put on this Royal Society of Medicine Wall of Honor. The first one is our great educator, Dr. Qais Kubba, who's many of you will know, and he taught us in medical school, and he's been a teacher of Sangani for generations. So it was one of probably my proudest moments that I was nominated to this role. Yeah, as I said earlier, I'm planning to visit Iraq. I don't know when, but inshallah, hopefully soon. As I promised Dr. Hilal, Dr. Umnia, Dr. Nassar, who is a friend of mine, we did our medical rotation together, like the foundation training. الإقامة الدورية. We were together in the medical school, in the مستشفى القادمية in Baghdad. We had very interesting and lovely days and lovely memories. So it would be great to refresh these memories and do some work with Wasat University, with Baghdad University in the north of Iraq. And inshallah, I think I will be going to Erbil in March for the Kurdistani Psychiatric Conference at the invitation of the board there. So it's the beginning of the year, and inshallah, there will be lots of activities in the next few months. So clinical teaching and learning. I mean, what's clinical teaching? We all know that the clinical teaching and learning is focused directly on patients and patient care. As Dr. Aussama said earlier in the beginning, in the first tutorial, that the priority of our work, wherever you go in the world, as a health professional, as a doctor or a nurse or a psychologist or any kind of clinician working with patients, the priority is to save patients' lives, is to create make happier patients and better patient outcomes and less complications in whatever specialty you do. So that's actually, it's the heart of medical education. Make the patient your priority. Everything else comes second. Pleasing your trainer, money, status, power, whatever. Everything comes really second. And you will, I mean, I think we all, when we were junior trainees or medical students, we said, actually, I want to be this specialty, or I want to do that specialty, and I want to get lots of fame and money and things. But actually, we didn't think about patients. When you come and the more you mature and grow into your role as a clinician, as a doctor, as an educator, you believe actually that no, the main thing is patients, creating happier patients, because that will in turn create happier society and happier doctors. So at the undergraduate level, I understand some of you are new trainees or new educators in this field. So medical schools strive to give students such clinical exposure as much as they can. And as Dr. Nassar and other people said, there are resources, some can be quite an obstacle. So you don't have many resources, you don't have lots of money to, I don't know, bring a large or an expensive sim model or something like that, but you could rely on simple techniques to teach your students things which it will be engraved in their brains forever. And for postgraduates, on the job, so clinical teaching is the core of the professional development. I mean, I remember days from my medical school in Baghdad when we had sessions by eminent doctors in different specialties, and things like they resonate in my mind like decades after we graduated. Something which is really quite emotionally involving and emotionally empowering, that you remember what your doctor said on this day or in that session, and that it will leave an engraved in long-lasting, sustainable effect on you as a doctor, as a clinician, and as a human being as well. I remember the words of Maghfur lahu, Dr. Saib Al-Gailani, who was a famous surgeon in the Baghdad Medical University. He sadly passed away of COVID in December 2020. He was telling us how he was, as a junior trainee in the 80s, he used to, I think he did the placement in Beirut American University, AUB, and he was pushing the wheelchairs, putting patients in wheelchairs. He said, I was never ashamed of that experience. And it's something that actually we did it. I did it like as a junior doctor, and even as a specialist when the need arises in the emergency department or in my department, you do, and you help out whenever you can. So things we are all, I mean, I'm always saying, I'm always very grateful. And I think the person who says, it's yeah, the teacher could have been a prophet or a messenger. because that's how we perceive our teachers, our educators, since primary school, secondary school, and after that in higher education. So what are the strengths of these of clinical teaching or clinical education? I mean, we are dealing with real life problems, as we said, and we are dealing with real patients, with family stories. We are motivated by relevance through the active participation. You take history from the patient, you examine the patient, you think and analyze, and your thinking pattern is modeled by your teacher. So if you are a good, excellent teacher, you can model the learning in your trainees, in your students, in your learners. It's the only setting in which the skills of history taking, clinical examination, reasoning, decision-making, empathy, and professionalism, all of these concepts can be taught and learned and as an integrated whole concept. If you go to the General Medical Council in Britain, the good medical practice, these are the things that they want us as doctors to do. Decision-making, empathy, being professional, being honest and open about your experience. This, if you practice this as a doctor, you're fine. And again, feel free to ask me any questions, maybe, or interrupt me. So I don't have the poll question and answer machine now, but feel free to answer any questions. And despite any potential strengths in clinical education, sometimes being criticized for its variability, something, that like busy clinicians, I have medical students today, 5 or 6, okay, I can't deal with them, or 10 or 20. Like historically, when we worked in, like I think in our medical school, we were small groups in Nahrain Medical School, like 5 or 6 per session. Whereas if you go to big medical schools like Baghdad Medical School, I think there were like hundreds or tens of people in each group or in each patient, and you can't really get a good flavor for the patient is presenting with. You can't hear sometimes what the educator is saying. So it's variable sometimes by the number of trainees and students, by how busy the clinic or the trainer is, the lack of intellectual challenge. You don't actually you are not challenged a lot about why you reach this diagnosis or this management plan, because okay, there is no time. There are 500 people that need to finish the session in about 45 minutes or an hour or something like that. And sometimes haphazard nature. It's busy clinic, busy hospital setting. The doctor wants to go somewhere else or wants to go to another lecture, or people want to finish early, so they want to leave. So these are some of the disadvantages or kind of hiccups or weaknesses, let's say, of clinical education. So yeah, clinical teaching is an educationally sound approach and frequently undermined by problems of implementation sometimes. So practicalities, as we said, time, the variability of the session, the number of patients, the presence of the patients and the trainers on the ward, and yeah, the environment. Sometimes I remember when we and when we worked in Iraq in the summer, it will be the temperature will be in the 50s, and there is no air conditioner or anything. People just want to leave the session, or there is no electricity in the hospital, and it's very difficult to sustain concentration and attention for more than 10 minutes, maybe. Something which I thought I will add to the slides today is values-based practice, something not directly related to the clinical teaching, but something I think it's very important to incorporate at an early stage in your life as a clinician, as a doctor, as a health professional. Values-based practice, it's what does the patient want? What are the patient values? So what we do this in clinical or in teaching sessions practically, we ask the trainees or the students to give us 3 values, any 3 words, anything that you would like to, what are the things, 3 values that will mean the most to you? Some people say money, some people say power, respect, happiness, I don't know, health, different things. And then you think about, if you reflect this on your patient, what does your patient want? The patient wants health. They want to live longer, or they want to live happier. And sometimes we give the examples of, okay, you are a patient with this terminal malignancy, and there are two options, A or B. And this is like just a hypothetical example of how you deal with patients with different values. So the first value, A, the option A, you could have the surgery to remove the tumor, but you end up with 50-50 survival rate, or 5-year survival of 50% or something like that. Let's say that's the first option. The second option will be like something more radical, surgery with chemotherapy, radiotherapy. It's more painful, it's lots of side effects, but again, you end up with maybe 90% survival rate in 5 years, but lots of side effects in the first 6 months of treatment. So which one you want? How long do you want to live? Something like that. So things like that are very important to discuss with your patients, because every patient will have different values. I might choose option B, whereas somebody else might use option A. We are all different. And it's interesting when you ask the patient or the trainees, when you do the session, why you chose option A. Some people will say, actually, I don't want to live more than a year in pain. Or some people say, actually, no, I want the full cure and I want to live for another 20 years or 30 years or something like that. So it's very important to check your patient value, because this is paramount and integral to what you do as a clinician. So that's your clinical judgment. It's exercised whenever you make a diagnosis and treatment decisions appropriate to the specific situation, and square down the options to your patient. What are the options, A or B, or more maybe options? So think about that when you discuss or when you see your patient, especially when it comes to life-changing or life-threatening scenarios. So how to become an excellent teacher? Share the passion for teaching. We are all here, you are all here because you are passionate for teaching and training. 10:30 in the evening today, and people are on a weekend, people are still listening and concentrating, and having clear, organized, accessible, supportive, and compassionate styles in terms of their teaching and what they want to do with the new and the newer generations. You should be able to establish good rapport with your patients, provide direction and feedback, exhibit integrity and respect for others, and demonstrate clinical competence. You should be a good doctor to be a good teacher, obviously. And feedback is one of the big or main concepts in medical education, as we've had this, I think, last year or the year before when we talked about feedback, that you should give your feedback to your trainees in a timely, consistent manner. Don't leave your feedback till a month later. You will forget. The trainee or the student will not remember what happened a month ago. Whereas if you tell them now what happened and why you did this, and like Dr. Aussama in the previous session said, debrief after the SIM training, debrief after what went well, how we can improve next time, something like this. So immediate feedback, timely feedback after the session is always very important. And something which comes to my mind, there was a lot of work around emotionally based or emotionally driven learning. I think we had lots of positive experiences, sometimes negative experiences from our teachers and trainers over the years. If you remember from primary school, secondary, and university, people who were quite strict and harsh and difficult to please sometimes as teachers, but they had the most powerful educational or learning outcome. You remember that the session that they did was the most powerful, and something which will stay with you for ages. In Iraq, we have the proverb which says, follow the one who make you cry, not the one who make you laugh. It's not always the case. I mean, it's good to be an approachable and friendly person, and as we said, establish a good rapport with your patients and also your trainees, junior trainees, and students you are teaching in any setting. Utilize planning resources, orienting strategies, use what you have. Dr. Nassar said we don't have, for example, lots of money to buy expensive instruments, but you can use local techniques or virtual or cardboard box to teach people how to do suturing and stitching. I remember, like in our medical school, despite everything that, like 90% of things were really great, I don't think there was a lot of emphasis on teaching us these basic surgical techniques, for example. I don't know why. I mean, we did clinical placements after each year, yani after the second, third year, and the fourth year, I think. We did like a month or 2 months in the summer holiday to go to the hospital and learn how to take history, or go to the blood bank and know how to take bloods and simple techniques. But I think it lacked some probably a variety of stations or variety of placements. We should have done more obs and gynae or more surgery and medicine and pediatrics. But again, I think that depends on the resources, the facilitators, the willingness of the trainers and the teachers themselves to do that. Again, some of us were really keen, so we will go and join registrars and trainees who are like, they finished their board training and will go and teach me this or tell me how we do that. And some of them were fantastic, and they were really keen to teach us and train us in different things. You need to possess a broad repertoire of teaching methods and scripts, engage in self-evaluation and reflection. Reflection is very important. It's one of the, if you go to the learning theories, there are lots of learning theories. One of them is about reflection. So how to reflect, what do you do? I think, again, when we studied in medical school, I think we didn't learn a lot about reflection. I think, but over the years, and people have started to learn more about this matter. So when I first came to the UK, I Googled reflection. What is reflection? And I think something like, مثل واحد يصفن يعني يسرح شوية. But it's reflection. It is part of صفنة. It's you analyze, and we do this, I think, all the time. Why I did this today? Why I was so rubbish in the exam? How do I do better next time? Why I made the patient angry or cry or something like that? How to avoid similar situation in the future? Why my teacher was angry with me today, or he told me off because I did something wrong, or maybe I did something he didn't like. I think I mentioned this example before. We were trained how to examine inguinal hernia in the 5th and 6th year of medical school. And like years later, I'm a GMC examiner here for the PLAB test, and we had to implement new stations in the PLAB recently. One of them is around inguinal hernia. So I had to be a candidate, like on the day, not the exam, the pilot test. And I did the inguinal hernia station, and the examiner was actually a surgeon, a practicing surgeon. He said, "No, well done, you passed the station." I said, "Really? I've never done it in my life, or I've never probably done it since I was a junior trainee or a medical student. But this is something that stayed with me over years and years." And we did it like, this is the importance of the good educator, the good evaluator, the good trainer, because the experience will stick in your mind. Even if you don't do surgery or obs and gynae or psychiatry or pediatrics, you will remember things, and you will implement these things in your clinical life, and how to change your practice as a clinician, as a doctor, and how to improve patients' lives. I'm glad that more people are coming to the lecture, so that's fantastic. Dr. Mehdi and other colleagues from different cities are joining, so welcome. Engage, reflection is very important. I think I would encourage everyone. I mean, I do it every day. Why I did that, and how do I improve next time? Draw upon multiple forms of knowledge. They target their teaching to the learner's level of knowledge. طبعا when you are a senior person, lecturer, educator, health professional in your field, you treat people according to their level of knowledge. So you don't treat them with like the higher level of, you don't have high expectations of their learning initially, because they are new to the field, they are new to cardiology, or they are new to obs and gynae. So you just lower your expectations initially and treat them and tell the trainers, target them according to their level of knowledge. It's time efficient. You should be planning your sessions properly, sharpen your expectations with time, clarify the roles and responsibilities, and allocate time for instruction and feedback. And also focus the learners on important priorities and tasks. So your task today is to take blood from the right or left arm, or to do abdominal examination, or to do this or that. And yeah, so make it more specific and more achievable. So a few words about each teaching session or each teaching setting rather than session. So small group teaching is not defined by numbers, could be 2, could be 1, could be 5 or 6. We define as any teaching situation in which a dialogue and collaboration between the two parties happen. So between the trainer and the learners. That's what the integral part of the learning process. So the teacher is still key to this learning. And the role of the teacher is not like when you go to a teaching session or a lecture when the trainer will give a 45-minute long lecture and they give lots of information and by the end of the day you are required to digest, or you might have a quiz at the end of the session. No, the short or the small group teaching, the teacher will facilitate the discussion. The trainees or the students or the learners ideally should be more prepared to do this session. So ideally they come with pre-preparation. They know what's been discussed today, and they know, for example, they read about the diagnosis and management of epilepsy, and they will discuss the management of epilepsy, and you as the expert will facilitate that or give them feedback, or interdear a session, you manage the session effectively and manage it according to the time, and you intervene as the specialist person. So if something is happening, something wrong is happening, or they're not giving the right information, you intervene. So the teacher is still key to the information, to the session. They coordinate, communicate, and inspire rather than to inform. So you tell them, I think as doctors, we love telling stories, and we tell them stories because that's something of the most powerful. If you know that in the last 15-20 minutes, I mentioned a number of clinical stories from life as a junior trainee or as a medical student in Iraq. So this will inspire you, and this will inspire other generations. It will inspire your students and trainees to do better in the future. So the strengths of small group teaching, and small group is flexible, so it's not, it's more organized. There is no noises or makudocha or lots of chaos, for example. It's very interactive. People will interact, 4, 5, 6, even 10 people will be like, you interact with each other very properly. If someone is a bit not lazy, but let's call not interacting well, or they're a bit shy or not very willing to participate, you could spot them directly and okay, actually X, Y, or Z, why you're not focusing. Or you could ask them a question, حتى تشوفها منتبه أو لا. What is the management of this? Or what are we up? Tell me more about this. And then it will be sometimes quite embarrassing for someone who's not paying attention, and then you put them on the spot. So it provides a good opportunity for interaction between the trainer and the trainees. Reflexivity, so it's interactive. We want, the teachers, the trainers will do many things, being authentic, being human, being honest, inspiring, as we said. And also engaging. So yeah, you could easily engage people in these sessions when you do small group teaching. I think we talked about this, the slide before, the student learner or the student versus learner led learning. As we said, in this small group teaching, this is one of the new methods. When I do it with my medical students, when they come to do 3 weeks or 4 weeks or 2 weeks of psychiatry, and I go and ask them to prepare a topic for tomorrow or for next week, and they will come and run the session between themselves. 80% is run by them, 20% is run by me, is like just facilitating, inspiring, and giving them feedback accordingly. Peer-to-peer learning, this is something that is, again, very powerful way of learning. Is different from, and I'm sure we've done it all in different settings. إذا تذكرون أيام البكالوريا ونراجع قبل الامتحان مثلا أو أيام الكلية, you practice with each other, you examine each other, you test the knowledge of each other as a student, maybe on a smaller scale, peer-to-peer learning. Tell me more about this, or what are the I don't know, different topics. I remember like one of the examples we did with my medical school friend, we practiced pathology as a peer-to-peer learning. Pathology was quite a dry topic in before preclinical school or preclinical studies. I mean, without seeing patients and things, it's quite difficult to know. I mean, we've seen slides and everything, but difficult to implement this or to reflect this or to image this or mirror it to real life and real patients. So it was a bit difficult to digest initially, but then with peer learning or peer-to-peer learning, we managed to pass our exams. We managed to learn more about pathology. And actually, when we went to the 4th and 5th year of medical school, things were much easier for us. So it's a fixed role, cross-ability tutoring. You're both at the same level sometimes, or maybe someone who is a year or two senior than you. So if you're in year 3, he could be in year 5, who will teach the younger generations. Like when we went, I think when we went in the 1st year of medical school, we went to the 5th year students who were oh my God, when I'm going to be a 5th year medical student or 3rd year, like with the Faiz Ta'ma, Dr. Faiz, he went to the same medical school with me, but he's, I think he was 2 or 3 years before, 3 years before us. So when we were in 1st year, I said, oh, يعني احنا شو وقت راح نصير صف 5 or صف 4, and it's now you think about it, you laugh. It was like years and years ago. So you see them as very big figures in your classmates and in your medical university. But they were like really, again, powerful teaching figures. I still remember things or books or notes or lectures or experiences which were taught to us by more senior medical students when we were in the beginning of our journey as students and doctors. And sometimes it's a reciprocal role, tutoring. Me as a 2nd year trainee or a student, I'll do the peer tutoring with my 2nd year fellow. We alternate. Sometimes I'm the tutor, sometimes they are the tutee or the trainee. I hope this makes sense. So the benefits of peer tutoring, I think we all know, we talked about it. That reinforces their own learning by instructing others. Students feel more comfortable talking about it. خاصة احنا we're a bit shy and ashamed and reserved, and you don't challenge your educator who's a senior consultant and specialist in his field or her field, whereas you're more likely to be informal with your friend or with your peer group person, keeping the boundaries of respect and everything aside. So it's definitely more informal and more comfortable for both parties. Peer teaching is financially efficient. ما تحتاج فلوس, ما تحتاج resources هواية. It's between two similar level staff members, and there is always direct interaction between the students, which promotes active learning. If you remember in previous lectures, we mentioned active learning or intrinsic learning is the main thing which stays with you forever, not like extrinsic learning. Extrinsic learning is linked to the exam. Okay, I want to pass the MCQ. So I just memorize the questions and I pass the exam with 60 or 70 or 80%. But actually, if you go to the theory or the analysis of the illness, why you have this, how do you diagnose pneumonia? How do you treat pneumonia? Or any kind of mental illness, what are the symptoms and diagnosis? And you are interested in the deep learning process, in the intrinsic learning. You acquire the skill for diagnosis and management, and this will stay with you for decades and for your life. So it's one of the actually good ways of intrinsic or promoting deep learning is this peer teaching or peer-to-peer teaching. And with peer teaching, it's one of the examples of constructivist or constructive learning theory. So it's like it's مثل اسمه how do you, for example, how you build a house from scratch. I mean, there is another theory, it's called like scaffolding. When you build a house, you have lots of metal and wood and wooden sticks, and you build a skeleton, and then you put the bricks and things over it, and then you build a house. So that's how things start. It's this skeleton of doing things, and then you flesh it out with adding more cement and material to the building. So large group is easy. We all know it is like lectures. Large group teaching, you have 500, you have 200, you have 100 or 50 people. It shouldn't be stressful for teachers or trainers, and shouldn't be really inactive for students. You need to involve your trainees or your students. We've all been through lectures where the teacher will go on slides or forever, and then you just take notes and you don't take opportunity to think and reflect. There is no interaction. And then by the end of the lecture, you will have a quiz, maybe tell me more about this or answer this or that question. So you should make it interactive and active for students rather than inactive and stressful for everyone. So yeah, it's give the trainers, it's time efficient because you're teaching 50 or 500 people in 1 hour. That's good. Give the teacher the opportunity to convey the basic knowledge, basic and necessary information, and help the students to gain a big picture understanding of the course and make links between different components, and also help the learners to see the relevance and applications of what they are learning, and help students consolidate their learning and give them the opportunity to meet and mix with more peers. طبعا هذه هي ideal aims or goals of a lecture. I'm sure we all know that many of the lectures will not satisfy these goals, will not achieve these goals, which is wrong. But that's what you need to make it engaging, empowering, and encouraging people to reflect and analyze the information they are getting. Because reflecting and analyzing is one of the, if you do it like the pyramid of learning, it's the top function of the human brain, of the cognitive process of learning. Analysis, evaluating and analyzing the information is the top concept in learning. Like I know why, for example, why myocardial infarction happens, because narrowing of the arteries and then chest pain and then whatever. But you don't analyze. So if you analyze and evaluate, actually you think about why the arteries are narrowed and why the oxygen is getting less and why the pain is happening and all of these things. So this is, and then this will stick in your mind, and then you'll be a better clinician and you can answer the questions much easily and you have better knowledge of that topic. And this should be conveyed in the lecture itself and also in clinical sessions. Bedside teaching, we all love it, is defined as the teaching in the presence of a patient and is the core teaching strategy during the clinical years of a medical student. We all had very interesting sessions. I could tell you these stories for days. Some of you will we had also positive and also sometimes negative experiences with some of the teachers who are, if they will, attract your attention or tell you off if you're not focusing, or you're probably not paying attention or not participating well in the teaching session. So this is again one of the powerful ways of medical education, indeed. So the challenges of this session or these sessions, sometimes busy clinical session, as we said, sometimes the session is short, no time to elaborate teaching. When we are sometimes you get families and relatives, or the doctor will be interrupted by other doctors or other commitments or people asking him questions, multiple learners, brief teacher-trainee interaction, and patient care demands usually take priority. This must be addressed. So your priority is your patient. Sometimes I think we did that as part of, we were medical students, and our main interest is to take history from the patient. Sometimes you exhaust the patient, you ask them lots of questions, and it will like, again and again. 5, 6, 7 students asking the same question or similar questions. You need to make the patient your priority. I know we were probably all eager and selfish and want to have more knowledge and want to achieve and pass the exam. But again, think about the other party and how this could be tiring for them as patients or relatives. Multiple patient problems could be addressed or must be addressed simultaneously, so the teachers cannot focus on one problem to teach. learning and service take place concurrently. So you see the patient, you examine them, you give them the treatment as the doctor, but also you teach the trainees and the students, and they observe you, and they could act as a role model. They see you as a role model doctor and the clinician who's treating the patient as a human being, treating them with respect and dignity, and then giving the ideal treatment plan, medical or surgical or any modality. And diagnostic questions are often settled by follow-up of the empiric treatment. The teacher and the trainer should always guide and be a guide and facilitator rather than information provider. مو احنا spoon feeding نعطيك كل المعلومات وانت روح اتعلم. No, you should be a facilitator and a collaborator, an empowerer. You should empower your trainees and your students to examine the evidence, why this is happening. Read the evidence, go for search for papers, and then come back with theories and implement them practically. So I think this will come to the take us to the end of the scenario of the tutorial. I think I thank you very much everyone for staying till 11 o'clock in Baghdad, in Iraq now. Just end with some nice pictures. In Qatar, I went to see the World Cup last month, and it was a huge pleasure again to talking about medical education. Dr. Riyad Abdel Sattar, he's our urology professor in Iraq, and these groups, the men here are they're all graduates of Saddam College of Medicine, Nahrain College of Medicine now. Hussein Turki on the left, pediatric surgeon in Dubai. The man on the left, Umar Isam in Qatar, Mustafa in Dubai, me, and Oussama Saadi. We're all graduates at different stages of the medical school. And if Faiz Ta'ma was here, he will remember some of them. Hussein was in Faiz's medical group, in the second group of the medical school. And I was at the pleasure of meeting Dr. Mu'taz. He's the forensic medicine teacher in our medical school. He was in London. He left London actually today. So that picture is very fresh. I met him 2 days ago, and we had nice memories and nice gathering and nice quick dinner before I came back to Oxford. Any questions? Thank you very much for listening. It was really interesting for me, and I hope it was for you as well. Thank you.
Thank you so much, Dr. Hasanen. You never cease to amaze us each session. We have a question from Dr. Nassar. Dr. Nassar, please go ahead.
Thank you.
السلام عليكم.
عليكم السلام.
شكرا جزيلا دكتور حسنين. أنا باكر طيارتي لازم أطلع لها نص صبح بالأربعة صباحا، وبسبب محاضرتك راح يصير عندي مشكلة ما أقدر أعوفها.
يجوز تتأخر طيارة نصير.
شكرا جزيلا، الله يحفظك الله يسلمك. شكرا جزيلا على هاي المعلومات الرائعة. حقيقة أنت دوما النفس الرائع والوجه البشوش والصحبة الطيبة. إن شاء الله نلتقي في واسط، وترحب بيك جامعة واسط وكلية طب واسط بالوقت القريب. أنا حقيقة بس أحب إنه فد سؤال أطرحه. رأيك بالفيدباك. الفيدباك إحنا دائما إحنا طبعا بالانتجريتد موديولز وعندنا سيستم اللي اعتمدناه، عندنا فيدباك لوت اوف فيدباك. رأيك إنه كل لكتشرز لازم تسوي فيدباك؟ أنت لو عندك فد سبيشال انتيتيز مثلا لكل موديول لازم عندك في نهايته، في نصه، في بدايته. اريد الاراء يعني العلميه الثابته في هذا المجال، واكون لك ممنون. شكرا جزيلا.
شكرا وبالسلامه دكتور نصير. يعني to answer your question، هو الفيدباك depends after the performance. انت الطبيب or the trainee or the student, when they do the clinical task, when they examine the patient, when they take history, ideally you give them the feedback after their performance. So if you have a group of 3 or 4, for example, after each trainee or student examining the patient or doing the task, ideally give them the feedback at the time. Because if you leave it to the end, انت راح تنسى. هو جزء تعطي الفيدباك تنخبط mix with the other patient, with the other trainees. So it should be timely and it should be consistent and honest. طبعا you should be open and honest. Don't انت ما راح تعطيه feedback غلط طبعا. انت you'll give him the right, honest, candid feedback. Ideally, yes, it's immediately after the performance, after the session. after the examination. It's difficult to have feedback after a large tutorial because you don't get that. You give feedback to the trainees, to the students immediately after the task. I think this is my simple answer to the big question.
شكرا جزيلا.
شكرا.
How you encourage your students, your يعني observer or to go through the feedback? What's your opinion?
How to
encourage them to go through this feedback, because sometimes we يعني نلاحظ احنا طلابنا يعزفون عن اداء الفيدباك. فرأيك انه شنو الآراء انه تعززهم؟
يعني هو the best thing is to encourage them to give feedback, because you tell them that this is the way of improving their learning process. Feedback is very essential to learning, and it's one of the theories, one of the concepts or theories of learning. And to implement, when you give feedback, you're actually learning as the person giving the feedback, and also the other party, الشخص اللي يتقبل الفيدباك, he's also learning or she's learning about their experience. So if you encourage them or tell them that actually this is an essential part of the learning process, and you have to take part in the طبعا هي مو mandatory, بس هو الأفضل أنت you give feedback, or you give feedback about if you're doing peer-to-peer teaching or peer-to-peer training, you encourage them to, tell me more about this. Even if it's a bit critical, maybe it should be a bit critical, maybe it should be positive criticism, constructive feedback. We call it constructive لأن أنت ده تبني شخصية الطبيب أو ده تبني شخصية الطالب. Shouldn't be critical in a negative way. لا. And okay, you did this, you focused a lot on the history, you didn't focus on the examination, or I don't know, you didn't focus on the details of the pathology here, and you focus on other things. So this is constructive feedback. For the next time, they will know how to avoid these mistakes and do it better, if that answers your question.
أشتيدك شكرا جزيلا. حقيقة بس أنا تجربتي كانت إنه يعني إحنا دائما نتلقى من الطلاب الفيدباك، يعني من يكملون المحاضرات أو من يكتملون فد موديول معين. No, we take the feedback from them. مو إحنا اللي نعطي، يعني هاي من teaching process نقول عليها إحنا اللي نعطيهم الفيدباك. أنا حقيقة تجربتنا إحنا يعني لاحظنا إنه الواي أوف encouragement انه التشينجينج اللي يصير، يعني احنا لاحظنا انه من عندنا فيدباك معين نراويهم بالمباشر انه هذا حصل التغيير من الطلب مالتكم، انتم لاحظنا انتم طلباتكم تصير هيجي، وهذا سويناه بناء على هذا الطلب. لاحظنا بهاي الطريقه زيدنا الاعداد مثلا بالفصل الثاني يعني لقبولهم يعني لاستقبالهم انه هو اجابتهم على الفيدباك مالتنا. هاي حقيقة تجربتنا احنا يعني ويا الطلبة.
Which is very good. هي مو سهلة. المهمة انه it's not easy to give feedback on your teacher or your trainer. This is something that is very important because يعني انت مثل ما قلنا انت encourage them to give feedback because this is part of my development as a trainer, as a teacher. How you do it is up to you, whether you do it orally like in the session or you take it on paper, like give them a piece of paper, an evaluation form. We give evaluation form after each session, for example, when you do scientific events, and they will rate it out of 5. 5 is great, 1 is not very good, and how that can be improved, for example. Or you do it online, and there are online platforms like links, like Google links or Google Forms. Google Forms, yes. Google Form, they give honest feedback. هو مو انت قباله ما يعرف انت منو اللي يعني anonymous. You don't know who is writing the feedback. Or you reflect as a teacher, as an educator. Actually, they are probably saying the right things. Or I focused a lot on large bedside teaching today. I should do more on small group teaching next time. So yeah, I think this is important. And I think you are doing it in the right way.
شكرا جزيلا عزيزي، الله يحفظك وإن شاء الله سعدنا جميعا. شكرا دكتور هلال على هاي الصحبة.
Thank you. شكرا.
So much. So speaking of feedback, everyone, we have a feedback form that the team has posted in the chat box. So kindly you go to the feedback and tell us your opinions and remarks towards tonight's session. So any more questions or opinions to Dr. Hasanen? Okay, so I guess this wraps up the night. Everyone, thank you so much for your listening, attendance, and participation. Special thanks to Dr. Hasanen and Dr. Aussama for their amazing presentations. This is the end of Module 1, an introduction to teaching. We hope that you've grasped the aim behind this course because, as I said earlier, teaching medicine is not like any other profession. You are a role model for many generations to come. And speaking of that, our next module will be about the good teacher. So stay tuned to the activities and the sessions that we will be having next Thursday. Thank you so much. I've had a lot of fun with all of you. Enjoyed these nights, especially. I hope that you enjoyed it too. Stay safe and don't forget the feedback. Thank you so much and good night.
Thank you very much. Thank you. Hello, Dr. Nassar. وين رايح؟